Welcome to Sky Women. I'm your host, Dr. Carolyn Moyers, a wife, mom, and board-certified OB-GYN. This is a place to educate, empower, and inspire. Join us each week as we share the power of women's stories. Real women, real stories, real inspiration. Put on your stretchy pants. Let's get going. Welcome, Sky community. Welcome back to an episode of Sky Women. Today, we're talking all about testosterone and testosterone use in women. I am using two resources here to discuss this. We're talking about testosterone use for the hypoactive sexual desire disorder in postmenopausal women. And I am using the NAMS practice pearl that was just released March 9th of 2023, as well as the global consensus position statement on the use of testosterone therapy for women. So when we're talking about testosterone therapy in women, a lot of times, because I've seen it, we have hormone therapy clinics on every corner, and women are getting injections, women are getting pellets, a number of different uses of testosterone. And I'm significantly concerned by this. And as we kind of walk through this, I think that you'll kind of understand why. So there's no clearly established indications for testosterone therapy in women. I'm going to say that initially. There are several clinicians that treat women with testosterone for decades with the intent to relieve a number of symptoms. In most countries, testosterone therapy in women is considered off-label, right? However, testosterone is also a female hormone. We think of it just as a male hormone, estrogen is for women, testosterone is for men. No, that's not true. We make testosterone as well, and our testosterone levels drastically drop as we age. So kind of looking at this broader picture, I'm going to just walk through a lot of this practice pearl. Actually, you could read it yourself, but most people don't have time to read or the interest to read this. So I'm going to try to bring it to the public and help it to make sense. So let's just talk about definition of what is hypoactive sexual desire and how often does it happen, right? So decreased sexual desire with distress has an estimated U.S. prevalence. So it's in approximately 12% of women between the ages of 45 and 64. However, I will tell you that I see the entire age range of women who tell me I'd be perfectly fine if I didn't have sex again. A little, right? So just know that you are not alone in this. This is probably underreported because I think a large majority of healthcare providers aren't asking about your sex life, right? There is an easy couple of questions in this questionnaire that ask specifically, do you feel like your desire is less than it previously was? Do you wish it was better? What do you think is contributing to your decreased sexual desire? And is it distressing to you? I mean, it's as simple as that. So hypoactive sexual desire is defined as persistent or recurrent deficiency or absence of sexual fantasies or desire for sexual activity. And this is the kicker, with marked distress or interpersonal difficulty. So is this creating stress for you or stress in your relationship? Okay. So it's important that a clinical assessment involving identification, modification, management of biological, psychological, sociocultural, and interpersonal contributing factors is done before starting testosterone therapy. However, I find this a little funny because I think when men come in with a low sexual desire, the answer is biology. Let's just give them testosterone, right? It's never like, oh, have you tried acupuncture and have you gone to counseling? And, have you considered this? Have you considered that? Because with women, it's all like it's in your head, right? And so this is just wrong because we're just treating the men. And then what are we doing for the women who are having sex with the men, right? We deserve to enjoy that pleasure as well, right? So that evaluation is going to include us asking about all aspects of sexual functioning, arousal, orgasm, pain, right? This is one that I find a lot. If it doesn't feel good, you don't want to have sex. Your brain is smart. There's nothing wrong with you. How do we treat this, right? So targeted physical and gynecologic exams. So really examining the vulva, the introitus, the opening of the vagina. Where are we having pain? Is it the pelvic floor muscles? And then sometimes laboratory testing when it's indicated. So Testosterone modulates sexual behavior. Testosterone and its precursors are synthesized by the ovaries and the adrenal glands. So these are the organs in your body that are making this. 50% of circulating testosterone is produced by peripheral conversion of androgen precursors. So we have these little precursors running around in our body, and in our periphery, it's actually getting converted. So androgen levels decline with age. They drop abruptly with a bilateral oophorectomy. So if you're having your ovaries removed, they drop drastically. Although serum testosterone levels do not correlate with the presence or absence of hypoactive sexual desire disorder or its severity, there is a correlation between testosterone concentration during therapy and improvement of sexual desire. So let me break that down. If your levels of testosterone, so say you have low testosterone, but you don't have a decreased sexual desire, well, then it's not a problem, right? However, if you have low desire and low testosterone levels, and monitoring those testosterone levels will help with your therapy, because we do not want to put you in a supra-therapeutic level. We want to keep you in a female therapeutic level. And it is associated with an improvement in sexual desire. Okay. Transdermal testosterone dosed in a normal premenopausal range improves sexual desire and reduces sexually associated personal distress in naturally and surgically menopausal women with hypoactive sexual desire disorder. What is a surgically menopausal woman? Just like I mentioned before, if you have both ovaries removed, you are surgically menopausal, whether that is because you had severe endometriosis or you had significant ovarian cyst or dermoid or an ovarian torsion or an ectopic pregnancy, whatever, typically your ovaries are not removed with an ectopic, but however, if you had a torsion or something of that nature, would come out. It also improves the frequency of satisfying sexual events. So this is testosterone therapy will improve the satisfying sexual events, arousal, orgasm frequency, pleasure, responsiveness, and self-image. So transdermal testosterone can be given as a patch, releasing 300 micrograms of testosterone per day, or a manufactured cream delivering 5 milligrams of testosterone in 0.5 ml base or 10 milligrams per milliliter daily. And it results in levels within a normal premenopausal range. So that's kind of our goal, not these high super therapeutic levels. Transdermal testosterone administered in physiologic doses, like we just mentioned, for 24 weeks in clinical trials resulted in an increase in acne and hair growth. So always some side effects, right? Without other androgenic effects seen with supraphysiologic levels, such as voice deepening or alopecia. So you're having little spots of hair loss. Lipid profiles, carbohydrate metabolism, cardiometabolic markers, and renal and liver functions were unaffected. Mammogram breast density didn't change with transdermal testosterone, but trials were insufficient to assess long-term breast cancer risk. And there were no serious adverse events seen with physiologic use. So who do we treat? Who do we recommend treatment for? Transdermal testosterone is recommended for postmenopausal women with HSDD, that's hypoactive sexual desire disorder, not related to modifiable factors or comorbidities. So for instance, if you have diabetes or neuropathy related to that, or significant other health factors that are affecting your sexual desire or affecting blood flow to the pelvis, those things need to be addressed. Just slapping some transdermal testosterone on is not going to fix this. There's limited data to support the use of late reproductive age premenopausal women. An expert opinion suggests that the management of women with premature or early menopause should be the same as postmenopausal women presenting with HSDD. So wherever you land in terms of premenopausal, premature menopause, or postmenopausal, the recommendation is still the same, that we're going to keep you in that physiologic dosing for premenopausal women. So it's important that if you're starting hormone therapy, there's a discussion about the fact that it's off-label use, benefits, risk. So basically an informed consent. Testosterone formulations that deliver a therapeutic dose appropriate for women are generally have not been approved by national drug regulatory authorities, hello FDA, except in Australia, where a transdermal 1% testosterone cream is available by prescription. Speaking of that, if you're watching on YouTube, you can see that this is what the testosterone gel would look like if you were to get it in the US. It comes in this little tube. I prefer this versus the pack. You puncture to gain access to the medication. It is 1%, so 50 milligram testosterone per a 5-gram tube. You're only applying a pea-size amount to the back of your thigh, to your buttock, and you're allowing it to dry. A pea-size amount daily. That's it. Now, when an approved formulation for women is not available, it's reasonable to prescribe this off-label and an approved formulation for men, but we use 1/10 of the dose. So that's what I was just showing you, 1/10 the dose. So this would actually last you well over a week. You might need 2 tubes per month. I mean, it goes a long way, right? It goes a long way. So transdermal therapy provides the most physiologic form replacement. So it's mimicking your natural body, your premenopausal body with plenty of testosterone aboard. This is the most physiologic form of replacement. Intramuscular injections and subcutaneous implants need to be avoided because of the result of the super physiologic level. So we have really high testosterone levels, and oral preparations aren't recommended because of the adverse lipid effects, including a reduction in that HDL, which we often refer to as our good cholesterol, and an increase in low density lipoprotein. So that LDL cholesterol goes up. Okay, so we've mentioned many times, dosing should be targeted to achieve total testosterone concentrations in the physiologic premenopausal range. I can't stress that enough. The starting daily dose for women is 1/10 of a 1% tube or packet approved for daily use in men, which typically equates to 3 tubes or packets per month. Transdermal preparation should be applied to the back of the calf, the upper outer thigh, or the buttocks. Patients should be counseled about potential transference from the application site to the skin of young children, female partners, or pets. The risk of exposure for male partners is minimal. Again, though, if you're putting this on your thigh or your buttocks, allowing it to dry, and then putting your clothes on, really no risk, very minimal risk. You're not going to be rubbing up on your babies or your pets or anything like that to get a transference. Okay, so when we start hormone therapy, what is the time frame that you should see your response, right? Because this is what everybody wants to know. When am I going to get relief for those symptoms? So we monitor you closely, looking at sexual desire, your response to sexual encounters, a decrease in personal distress. Women typically note an improvement in their sexual function in 6 to 8 weeks after initiating treatment, although it could occur as early as 4 weeks. Maximal effect on sexual desire and satisfaction typically occur in about 12 weeks. So I typically bring patients back within 8 to 12 weeks. We typically do a 12-week trial and see what kind of effect. And if it doesn't help, we stop it. No big deal. Reduction in sexually associated personal distress occurs in about 4 weeks, with continued downward trend over a 6-month period if it works for you. Treatment needs to be discontinued after 6 months of lack of clinically meaningful improvement. So if you're not seeing a significant improvement, we can discontinue that. If you do see an improvement on testosterone therapy, then you can continue your treatment for up to 12 months and consider taking a drug holiday to see whether treatment is still required. And if ongoing therapy it can be maintained for the improvement of HSDD. So how are we going to monitor this? So typically, we typically will do a total testosterone, free testosterone, and a sex hormone binding globulin. These are the labs that we typically look at. Total testosterone rather than free or bioavailable testosterone or free. Androgen index is the best available measure. Total testosterone should not be used to diagnose HSDD, because remember, do you have low sexual desire, decrease in sexual desire? Are you distressed by your sexual desire? But it can be used to serve as a baseline to exclude women with mid-range to high baseline testosterone levels before initiating treatment. Also, sex hormone binding globulin should be measured because women with levels above the normal range are less likely to benefit from therapy. So if you have that elevated sex hormone binding globulin and that your free androgens are binding to that sex hormone binding globulin, you're less likely to see a benefit from testosterone therapy. Total testosterone therapies need to be, or total testosterone levels need to be monitored to maintain concentrations in that physiologic premenopausal range and to ensure that total testosterone doesn't significantly exceed the upper limit of the reference range. Generally, this is around 27 to 38.6 nanograms per deciliter. So total testosterone levels, it's recommended that we reassess them at 3 to 6 weeks after starting therapy. If the dose is increased, then we're going to base that on clinical response and blood level. And total testosterone would then be repeated within the 6-week time frame. When testosterone levels are maintained in a premenopausal range, androgenic adverse events are rare. So remember those events we talked about earlier, like clitoris enlarging, deepening of the voice, hair growth, acne, issues like that. Typically, that is not, we're not seeing that when we're keeping it at just normal physiologic ranges. If they do occur, the dose needs to be decreased or can be stopped. Measurement of baseline liver function and a fasting lipid profile is recommended. So any of my patients, before I'm initiating them on hormone therapy, I need to know what their kidney function is, what their liver function is, what does our cholesterol panel look like. As well as, so annually, every year, we're recommending that we monitor lipid profile, liver function test, and a CBC, a complete blood count. So twice a year or yearly when initiating this hormone therapy. I'm going to re-record that. Patients should be assessed for signs of androgen excess. So those side effects that we talked about earlier, whether it's acne or hair growth in areas you don't want them, or a deepening of the voice or an enlargement of the clitoris, different side effects that you may not be thrilled about. If they occur, the dose needs to be decreased. We need to measure baseline liver function. Fasting lipid profile is recommended. Breast and pelvic exam as clinically indicated. Mammogram, according to our specific guidelines, which for most typical patients with average risk is annually. And then we're going to monitor semi-annually for the first year, so every 6 months for the first year, and then every year thereafter. We're going to monitor a lipid profile, so your fasting cholesterol panel, liver function test, and a complete blood count. Okay, so these are the areas that we need to assess whenever we've got you on testosterone therapy. Transdermal testosterone is recommended for postmenopausal women with HSDD, not primarily related to any modifiable risk factors. Like testosterone is not going to fix a bad relationship, ladies, okay? Or any comorbidities, so other health problems or concerns that may be contributing to low sexual desire. And it's really important that we use these different guidelines, position statements, these clinical pearls to really look at what are the detailed treatment guidance, what are the practice guidelines, so that we have a good baseline of evidence-based information for making these decisions for you and your health. Now, when I say that this is recommended for postmenopausal women, that is what the global consensus really is. Do we use it off-label in premenopausal women who have low testosterone levels and a low desire that is not contributed to any other factors? Absolutely, we do. But again, understanding there are side effects with any medication that we may initiate, but oftentimes the relief is significant and patients are willing to take that risk as long as you have proper counseling and informed consent. Then I think it's totally reasonable, especially if we're seeing a significant improvement in satisfying sexual events, arousal, orgasm frequency, pleasure, responsiveness, and self-image. I think most women would sign up for that. So talk to your healthcare provider if you think it might be right for you. Here's advocating for your health and better pleasure. Until next week, be well.
All right, Sky community, thank you for listening to another episode. This episode was sponsored by Sky Women's Health. As a reminder, we're in the Dallas-Fort Worth area, and we help relieve back pain and pelvic pain in pregnancy and beyond. If you are pregnant and having pain and you feel like you have no reliable way to relieve it, look us up at skywomenshealth.com, request an appointment, and we'll call to get you scheduled. As a board-certified OBGYN with a Neuromusculoskeletal Medicine Fellowship, I help you realign with hands-on drug-free treatment and relieve pain on the spot without medication. We'll help you maintain these results through your pregnancy and postpartum period. Every pregnant person deserves this, and we are so excited to serve you. You can find us on our website, as mentioned, or on social at Sky Women's Health, or you can call the office at 817-915-9803. That's it for today. Until next week, be well.